My talk is on focal HIFU, and I just want to give you a little background about myself. I spent my initial training years at the University of Minnesota for about 6 years, worked with Paul Lang and Fraley. Subsequently, I spent about 5 years at Harvard and then 10 years at UCSF. Peter Carroll is my contemporary, and then trained with Tanago. Very interested in minimally invasive therapy. In fact, we got the first of the 10 machines for cryo when it first started. I've done over 700 cryos, and we did a lot of work with Shinohara. I remember giving those courses on ultrasound sextant biopsies at that time. And subsequently, I moved on to Florida, where I was chairman of urology for several years, and now I've gone into corporate. So I'm chief medical officer for HIFU Solution now. HIFU Solution just uses both machines, and we provide mobile services. In fact, several years ago, I developed a mobile service company for cryo, which we sold to Endocare, now known as Healthtronics. So that's the disclosure. Again, I appreciate Dr. Nelson having me here to give you this talk. So treatment of prostate cancer, as we've heard over the last 2 days, is one of the most challenging public health issues today. Problems include undergrading and understaging of significant cancers, overdiagnosis and overtreatment of non-significant cancers, and treatment-related toxicity and escalating unsustainable costs. We've also heard today from several speakers and others that standard trust may detect clinically insignificant cancer by random chance. It also detects undergrades a lot, but today we're going to focus on this. So fear of missing significant cancers results in all men getting radical therapy and overtreatment. So this is the problem we're facing. The morbidity and escalating costs of radical treatment is unacceptable, and the USPSTF recommended no screening for prostate cancer, again, due to the harms from both treatment as well as screening. Due to the side effects of the overtreatment, the active surveillance is being considered more, and as Dr. Crook pointed out, it has increased from 10% in the early 2000s to as much as 40% of patients accepting active surveillance at present. Active surveillance, while it has less side effects, does have disadvantages. If you look at the PROTECT trial of active surveillance, 56% of men undergoing active surveillance actually received radical treatment, 20% because of progression, 36% because of anxiety or patient refusal. Only 44% stayed on active surveillance. The disadvantage of active surveillance is also seen in all the active surveillance protocols, as many of them from Hopkins, Royal Marsden, Toronto, etc. And you heard yesterday that there's progression in 30 to 57% over 10 years, and when active surveillance fails, patients get more intense therapy. In fact, the ASCO guidelines recommend that if you're going to put a patient on active surveillance, you have to warn them that when it fails, because several of them do, that you have to tell them up front that these patients may need more intense therapy, such as radiation plus surgery, etc., which causes more side effects because now they have more volume disease, higher grade, etc. Also, active surveillance causes psychological burden and anxiety, which I just showed you, resulting in half of these patients not going on it eventually. Most important, in the U.S., delayed diagnosis and progression due to active surveillance may actually result in lawsuits. We had a discussion at the AUA last year where a patient was diagnosed as having Gleason 6 cancer, put on active surveillance, standard trust, no MRI was done, and a year or two later developed Gleason 7 disease. Went to another urologist, had one lymph node positive, and then the first urologist was sued for not doing all the appropriate things. So we have to be very careful, and I'm not sure that many of the urologists in practice are willing to do this on younger patients. So enter focal or hemi ablation of the prostate, which may be a compromise between whole gland therapy and active surveillance. As Dr. Crook pointed out, we need a therapy that works in whole gland that has had long-term experience. She showed you several papers for brachytherapy, but I didn't see any results, and I didn't see any long-term follow-up. So I think when you're looking at this, we need to have some of that. Again, the exact modality that we use for focal therapy, we're not clear of, and I think some form of radiation will be a good competition for HIFU, but today I'm going to discuss with you what we know about HIFU. So focal therapy is versatile. You can have unifocal or multifocal therapy of target areas, hemi-ablation, which treats one half of the prostate, extended ablation, which can destroy one half plus portion of the contralateral side, and it can also be used in high-grade cancer as part of multimodal therapy. I'm not going to discuss much of that because those are different talks. So what are the advantages of focal HIFU? It may offer a minimally invasive option. It takes about an hour to do. The whole procedure takes about 2 hours between the setting up and the waking up and the patient going home. It avoids patient anxiety, psychologic burden, because instead of going on active surveillance, some of those patients may want to go on a treatment. It has good results compared to radical therapy, and it is still not a standard, but has potential for patient acceptance. What are the other advantages? It does not preclude radical therapy later. It preserves quality of life. The patients have incontinence rates and erectile function similar to active surveillance, which I will show you, and it may protect against lawsuits. It is less expensive and does not have escalating costs because you don't have the incontinence and life-changing potency type issues. So there are many available focal therapies: cryotherapy, HIFU, focal laser ablation, focal radiation, nanoknife, photodynamic therapy, and several others. There's a good review article that was reported in 2017 on this too, which I'll give you a reference to that. So what are the issues that we have to deal with? Efficacy of focal therapy to document lack of local recurrence on biopsy is currently at least the most accurate in my opinion. Because if you look at the Stuttgart definition, the Phoenix definition, or the Astro definitions, we still have cancer in the opposite lobe that may be treated, may not be treated, may not be discovered, so PSAs can vary. And PSA endpoint, therefore, in my opinion, is inconclusive in focal therapy. But the drawbacks of the current studies are most of them are non-randomized, they're retrospective, treatment protocols are variable, and definitions of recurrence are variable. Still, there's quite a bit of data on cryo and HIFU, which I will present. The first data on focal therapy was presented by Onik and myself. We did about 9 patients. That was in 2002. We called it the male lumpectomy. And in fact, one of the people who's funded my company, the HIFU solution, is a patient who I did a unilateral cryo on. So it had good results. 7 out of 9 patients remained potent. And since then, at least 10 studies have confirmed similar results. So these are some of the focal Hemi studies, and I've given you the data here. Bonn in 2006 has a follow-up of 5.8 years, 100% no recurrence on biopsy, which I don't quite believe. Onik in 2007, this was an extension of our studies, 55 patients. We also had this, again, follow-up is short. Ellis in 2007, 98.3. And so this has all been reported in this recent publication, which Emberton has reviewed. Here again, more studies. The ones that were previous were the older studies. Now there's 2012, 2014, and again 2015. Longer follow-ups, and the recurrence rate's a little bit more. But summary is that it's still under 15%. So that's good with 5-year survival. So I think some of this data is valuable to understand when we go forward. Now, the summary of focal and hemi cryos suggests that recurrence is 0 to 13%. Follow-up, this is mostly retrospective. There's likely some flaws in the recurrence rates because of the short follow-up. However, the trend suggests that focal and hemi ablation of prostate cancer is possible. Now, there is a randomized prospective trial that was just completed from 2009 from the French Urologic Association, and that started in 10 centers, all used MP-MRI, which is the current standard, as we all heard over the last several talks, fusion biopsy to stage and grade all cancers. Patients were over 50. They all had unilateral cancer, T1C, T2A, PSA under 10, all had central pathology review. Mean age was 64, mean PSA was 62. Most of them actually had Gleason 6 and some Gleason 7, about 26%. 111 patients. This is the 2.5-year follow-up. This is the longest follow-up to date. 86% no cancer in the treated lobe. That's pretty good results. 90% of the patients had biopsy. We also always have to look at how many of these were looked at. 19% of the patients had cancer in the contralateral lobe. Mean PSA at 2 years was 2.3, and 1-year continence was 97.2%. 1-year erectile function was 78%. So this is a again, the first study that suggests to us that Hemi ablation can work, and this was done over multiple centers and has reasonable follow-up, at least with the biopsy recurrence. Among these patients in the series who underwent secondary interventions such as radiation or surgery, there are no complications related to HIFU. Now, we have operated on patients who have had HIFU, and there is scar tissue, but in Hemi HIFU, it's easier to do them because the opposite side doesn't have it, so the radical prostatectomy can be done well. Some patients who had Gleason 6 cancer in the opposite lobe in this series are on active surveillance, and further long-term studies are needed. So here's a review of other Hemi HIFU studies, because it's not all of this was a randomized controlled study, and these are some of the non-randomized studies. So if you look at these studies, you can see here the results are pretty reasonable in terms of no recurrence on biopsy. I've not given you the data on the biochemical disease-free survival. They're also good, but I think they're still not as believable, only because of the different definitions, and we're still coming to a kind of a consensus on what they are. So here you have 2011, 2013, 2015, multiple studies, all have short follow-ups. Most of them have about a third of them are Gleason 7s, and about half of them are Gleason 8s. PSAs have been low, but there have been some substantial numbers. So both in HIFU and in cryo, I've seen these numbers. All the others, such as the brachy, the laser, the PDT, there's maybe one trial with the PDT, but most of the others have 9 patients, 5 patients. They're more like trials just to evaluate the study rather than actual data to justify the treatment. So what is acceptable results for Hemi HIFU as therapy? Most important is the lack of cancer on the biopsy-treated lobe. Now, they did have a 2000 consensus conference in Germany, and they decided that retreatment rate should be less than 20%, and whole gland salvage therapy should be less than 10%. They also decided that if there was a small amount of low-grade cancer in the treated lobe was present, it's okay. Now, in my review of these data, I excluded all those patients. So if somebody reported they had a 95% result, I took those out and said, if they had any cancer in that lobe, that's the ones that I've reported. So this is a little different from what they believe is good therapy. Having said that, advantage of Hemi ablation over focal therapy is that it minimizes safety margin around the MRI target lesion because we're treating the whole half. As you heard from Dr. Crook, she decided that based on her review of the studies, a 7-millimeter margin is okay. I will show you some data from Dr. Hashim Ahmed that he took a 10-millimeter margin, and even that was not good, because once you get to those kinds of margins, as she mentioned, you get large volumes of prostate you need to treat. If you're going to treat a 4 cc volume of prostate, that's more than half the gland. The value of focal therapy is not there. So in my opinion, Hemi ablation is the current way to go. It's more reproducible, it's standardized for protocols, for clinical trials. It does preserve erectile function and continence, which is what we're trying to do as what we call the disaster complications. Patients have more UTI or epididymitis, they're all self-resolved. So what is the data with focal HIFU compared to Hemi HIFU? There's been 2 trials, both from the same group, one in 2012, and maybe this is a more modern 2015, where they changed the parameters a little bit. And what you find here is that the results are not as good as Hemi HIFU. So you look at the results here, it's 23 and 34% recurrence, and as I showed you in the Hemi ablation, it was 5 to 6. This is quite normal, kind of logical, because if you treat a smaller volume and you're missing cancers, we all know prostate cancer is multifocal. A few years ago, if you just said even if you're treating half a gland, that would be malpractice. We're moving along here, but I think we have to be careful. We also looked at the data on 3 trials of focal laser, which has been published, and Herb Lepore had very good results, but everybody else had bad results. So if you look at it, it's similar to the focal ablation. So I think the focal ablation results are still not as acceptable, in my opinion. So focal therapy may not be ready for prime time. Imaging technology using MP-MRI, while able to detect larger lesions over 1 centimeter and Gleason 7, is unable to determine margins of tumor. But we do know that 30 to 60% of all diagnosed cancers are unilateral. It just depends on the series. The one that is 60% is the one I'm quoting from Dr. Turoff and Chaucy that was published in Journal of Urology. They had 704 patients. They went back and looked at the patients, and there was a high number that were unilateral. So hemiablation provides advantages of focal therapy such as continence, preservation of erectile function without risk of sparing cancer margins, and can be standardized in trials. What are the side effects? Hemi HIFU is essentially equivalent to active surveillance. This was news to me because I looked at the PROTECT trial, and the active surveillance patients, we actually have incontinence and ED 2 years after treatment initiation. And so you look at active surveillance, the PROTECT trial. This is the AFU randomized trial for Hemi HIFU, radiotherapy PROTECT trial, radical prostatectomy PROTECT trial. So you look at the incontinence rate, it continuously increases. And if you look at ED, it also continuously increases. So if you have Hemi HIFU, it's very close to the active surveillance. Another comparison is if you didn't want to just look at the PROTECT trial only, let's look at the trial before that, which is the PIVOT trial. And if you look at de novo incontinence at 2 years, both in the PIVOT trial, which was done earlier, very similar. So you can see there. So it reiterates the point. So Hemi HIFU maybe is ready for prime time. I'm not yet ready to say that, but it is a thought for you to consider. Gleason 7 disease, volume over 1 cc can be detected by MP-MRI if you have a good detection radiology system, and you yourself participate in that. It can be detected. Clarity of the margin is unclear, so hemiablation, in my opinion, is preferable to focal. A large percentage, a third to half of cancers are unilateral, and it may be a bridge between active surveillance. It allows men to enjoy quality of life, does not preclude future radical therapy. There's an unmet need for newly diagnosed men who are faced with deciding between active surveillance and radical therapy, so we may have a treatment that is possible for them.